have the presentation up. Good morning, everybody. Just a quick introduction about why we're doing this. So I basically wanted to give a simple message to everybody, whether it's primary care, internal medicine, all other specialties. We deal with the musculoskeletal. You know our diseases affect many systems. So a lot of you'll see our patients, whether it's at gastroenterology, hepatology, many other specialty. We will give you an overview. We'll have simple message, very practical. We don't want to go into details in terms of pathogenesis. So I was given the task to talk about the principle of management of gout. Very common problem. Unfortunately, there is increased prevalence in Kuwait since we have all these risk factors in our population, including diabetes, hypertension, obesity. So I'm going to go over very quickly in a few slides in how to manage gout, how we diagnose gout, what question you're going to be facing. So I'm going to take you over the skyline of Kuwait through a presentation in terms of the management of gout. So first of all, where we're going to face these patients. So most of the common scenarios are going to present with a patient who have a knee pain. Very common presentation in primary care, emergency department in the community hospital. You could have a one knee pain, you could have a bilateral knee pain, you could have a feet pain. So it's in terms of differential diagnosis of monoarthritis, you're always going to include crystals-induced arthropathy, whether it's a gout or pseudo-gout, whether it's due to the uric acid crystals or the CBPT crystals. The most important diagnosis to exclude it before you make a clinical diagnosis of gout is basically septic arthritis. So what are the common causes or the trigger factors for gout? By far, the most common one is the comorbidity that we face in our patients: obesity, hypertension, diabetes. Second, it comes the renal failure. In this part of the world where the weather can be very hot, dehydrations. Yes, we do have air conditioning, but we have people who actually spend some of their work time is actually outside, so they are prone to be dehydrated. So dehydration either by physical efforts or dehydration due to our medication, diuretics. Diuretics are very commonly used to treat hypertension in different level of care. So always think about these when you take history of the patient you're considering diagnosis of gout. In terms of cytotoxic drugs, I think by history is going to be obvious. Patient diagnosed with the space bug lesion or malignancy, and they started in the chemotherapies and they are prone. Most of the time, our oncologists start a prophylactic treatment because they know they're going to have a high uric acid and they're prone to have gouty attack. Renal failure, another common problem, worsening kidney function. Most of the time, the uric acid will be done even at baseline for other reasons. You know they are prone to have acute attacks. In terms of factor that can raise acidosis, so diabetic ketoacidosis, a common presentation. In a setting of diabetic ketoacidosis, or even patient had a history of diabetic ketoacidosis. Starvation, that's not a big problem. Binging alcohol, I think it's a problem over a weekend, and we see this all the time in Mubarak Hospital. Aspirin, low-dose aspirin is known to increase risk of hyperuricemia. Cyclosporin, not very common drug, but you'll see patients, either transplant patients or patients we treat for autoimmune condition that are in cyclosporin. Over-exercising, not a big problem, but we've seen people who recently gained weight. They have like 20 kg weight gain over the last 6 months, and suddenly he had the urge to go and exercise, and they did over-exercise, and they are prone to have acute gouty attack. High purine diet, I know this is what we tell all our patients. I would say it's not really a major factor, but especially except for those who really eat like meat every day in a large amount. If you eat like in a moderate amount, like a 1 or 2 meal of meat a day, I don't think that's a big effect. There is a big talk about the seafood, whether it's shellfish or shrimp. Again, in moderation, I don't think that's a big deal, but those who eat it like an everyday, yes, we may have to tell them to modify their diet. Lymphoproliferative and myeloproliferative, that goes back with the cytotoxic drugs. So these are the causes of the trigger factor for acute gout. This is by far the most common presentation. Usually they comes with a big swelling in their first MTPs. Most of the time in the hospital setting, we diagnose it by clinical history. Patient had history of swelling of the big toe, redness, they wake up, they can walk for a few days and it's resolved. Whether they take a painkiller or not, it resolves within a few days. And there's a recurrent attacks depending on their trigger factor. by far, this is the common presentation. In a few cases, I would say in a South Asian, especially Filipinos, because of the enzyme, they have a specific enzyme deficiency, we've seen very bad cases of gout. Tophi, erosions, polyarthritis can actually mimic rheumatoid arthritis. So in that specific population, I would consider also crystal-induced arthropathy. Now, what's happening in the primary care? There's no question that there is increased prevalence of gout in this part of the world. When a patient comes, let's say, with a right knee pain, you're going to ask yourself, is this gout? Again, by far, history is the most important. Have you had similar attack before? How long did it take to go away? Did it swell? There was any redness? Did you take an anti-inflammatory and it went away within 5 days? Have you ever had uric acid checked before? You have any family history of hyperuricemia or gout? This is all by far by history. I think most of the time, once you ask a few questions, you'll have an idea that whether this is crystal-induced. Again, you wanted to exclude septic arthritis. This is a different presentation. Either a direct inoculation of the bugs through a direct trauma, which is less common. The more common, though, is the patient who have infection somewhere else. Could be a pneumonia, urosepsis, and they're seeding their bugs through the blood to the joints. Again, history is important. Fever, night sweat, maybe a short period of weight loss, feeling unwell, cough. The history is going to guide you on that. Now, when you see this patient, you're always going to ask about what investigation. Please do not do uric acid. It's not going to be useful. This is a hyperuricemic state. Due to a trigger factor, the uric acid is going to precipitate in the joint. Theoretically, the level is going to be low. So there is no point of you measuring uric acid during the acute attack. You can treat the patient after 6 weeks, do the uric acid level. Most of the time we get consulted in the hospital, the uric acid is done already, and you see like uric acid like 400, like borderline. You know that if you repeat it after 6-8 weeks, it's going to be higher because during the attack, the uric acid is actually low. Important diagnoses exclude. We talked about the most important, septic arthritis. There is obviously other differential diagnoses. How should I treat gout? We'll talk about in another slide. How do I monitor? That's what I want to answer in the next few slides. So acute treatment, by far, if patient doesn't have a contraindication to non-steroidal, this should be your first line agent. I'm talking about 5 days, maybe 7 days maximum. If you don't have history of peptic ulcer disease recently or renal impairment, you should advise the patient to have rest and start a non-steroidal for 1 week. If the patient have history of bleeding or peptic ulcer and you're concerned about their using an NSAID, you can use also a COX-2 inhibitor. We've seen a lot of patients started on steroid by the time they refer to our hospitals. If you want to use steroid for reason the patient had renal impairment, patient doesn't want NSAID, he had history of multiple allergies, whenever they take NSAID they feel itchy and have rashes, then you can start oral steroid. But please do not exceed 30 milligram. Most of the time 30 milligram. This, I told you by definition, these people feel better within a week. You will probably need a 30 milligram and that will do the job. If you're trained to do an intra-articular steroid and you have one joint, I even prefer to do an intra-articular. It's a local injection, it goes in a one joint, there's no minimum systemic absorption for like a few hours, and you avoid all the side effects of the other medication. Colchicine, I don't think we're using enough colchicine, or we're not using it in the right amount. Most of the time we get referred to the clinic where patients have been on colchicine 1 pill a day and that didn't do the job. 1 pill a day is not going to do the job for you. You're going to need to have at least BID or TID dosing of colchicine. It's very effective, very old drugs. We know very well the side effects, and most of the patients actually tolerate it. And actually this is one of my choices to do the overlapping between the anti-hyperuricemic drugs and because you know when you started there is a chance you have a flaring of disease, which we're going to talk about. So if you wanted to use a colchicine, use it in at least a BID dosing or TIDs. You know that, for example, when you treat patients with familial Mediterranean fever, we use it even more often. We give like 1 pill every 4 hours or even 3 hours. So don't be concerned. Again, we're using it a very short time. Yes, be cautious of renal impairment. You probably won't be your choice of renal impairment. You're going to be given an oral steroid. Duration of treatment, I was asked this question many times. For how long? Once you have a complete resolution of pain, continue the drug for another 48 hours. That's it. 5 days, 6 days, 7 days, patient had complete resolution of pain. Continue the drug for another 48 hours and stop it. There is no point of giving 2 weeks and a 3 weeks prescription. Most of the time, the attack will be resolved within 10 days. So further management, and I expect everybody in this room to address these points, because you're going to see them for these reasons. Tell them about their obesity. There's no question that obesity decreases renal clearance of the uric acid, so they have to reduce their weight. They're probably going to be upset with you because 100 doctors told them before and said, you know what, it's going to be 101 now, because this is one of the reasons that you need to lose your weight. You're going to need to decrease uric acid level. High purine intake, we talked about this. I don't make a big deal of it unless the patient eat steak every day or eat meat, red meat, and every day I usually tell them take it in moderation. There is a study to back me up that it's not really having a big impact. It's really the comorbidity, the obesity, the hypertension, diabetes has to be well controlled to monitor the hyperuricemia. We also talked about eating the shellfish and the shrimp. Alcohol intake, by far, when I was trained in Canada, this was the most common one we see over the weekend. Binging alcohol was the most common cause of gouty attack. Plus, these people are obese and they have the other comorbidity. Soft drink, we don't usually address these soft drinks. Soft drinks do contain fructose, which make our people also prone to hyperuricemia. So if they've been drinking too many Pepsis and Coca-Cola, I think we should be addressing that with them. Maintain fluid intake. I told you about in this part of the world, dehydration is very common, especially for those who spend some time working outside in hot weather. And talk about the moderation of the exercise. I think we have very few exception of people who are over-exercising. They go to the gym twice, and we have to tell them that this is going to be one of the triggering factor. So, once you treat the attacks, you gave the patient the rest, NSAID, or a steroid, and the attack is gone, you're going to ask yourself, what do I need to address in terms of lowering their serum uric acid, or do I even need to lower their serum uric acid? So the aim of these drugs is going to be to dissolve crystal and prevent further formation, prevent acute attack, resolve TOFI because it's disfiguring on their elbows and their ear lobes around their umbilicals, and also prevent tissue damage. This is there is a few cases where you can have a chronic arthritis which can lead to erosion, and the specific erosion changes on the x-rays. So who are these people? And by far, I think this is the most important slides I have in my presentation. I have to tell you that since I came back from my training, I stopped more allopurinol than I started allopurinol. I've seen a lot of people put in allopurinol with no good reason. There is no study up to now showing that treating asymptomatic hyperuricemia is going to make any changes in terms of preventing gout, MIs, strokes. There is many studies in the past, small ones where they have a lot of noises. All the big studies which involve thousands of patients, there is no evidence of treating asymptomatic hyperuricemia. So please, don't start everybody who has uric acid of 500 and 600 on allopurinol, all the new drugs that we're going to talk about. You have to ask yourself, do they have one of these criteria? And these criteria are, if you have more than 3 attacks per year, we have many people who have 1 attack per year and they started right away in allopurinol. I don't think allopurinol is a good drug, but it also has some side effects, which we're going to talk about. When I said more than 3, so you really have to have 4 attacks per year to start to be a candidate to start hyperuricemic drug. Evidence of gouty TOFI, disfiguring, it actually can get worse and has to be treated to lower uric acid, so that's one indication. Renal insufficiency. Now, when I said renal insufficiency, that's actually a tricky indication because it has to be a renal insufficiency secondary to high uric acid, which is a uric acid uropathy. This is a clinical diagnosis by nephrologists. They actually involve doing a 24-hour urine for uric acid clearance, and most of us, we don't do that routinely. So don't say, oh, because the creatinine was 120. Especially, I told you, our patients are already diabetic, hypertensive. They may have high creatinine due to their other comorbidity and not specifically due to their high uric acid. And the history of uric acid stone, again, a lot of people come to us, say, oh, I have kidney stones. Some of us, at least in our hospital, we do send the stones for analysis and we tell which kind of stones you had. We can tell you if it's uric acid or a calcium stones or oxalate stones. So it has to be a uric acid stones. Patients who remain on diuretics, we have a defined clinical entity where patients have a recurrent attack due to their diuretics, and we try to negotiate with the treating doctor, see if they can switch them diuretics, and for different reasons, we are not able to take them off diuretics, so I will say these people are indicated to have a hyperuricemic drug. So more than 4 attacks, more than 3 attacks a year, evidence of TOFI, history of renal insufficiency, history of stones, and those who remain in diuretic. These are the people who I'm going to consider to starting uric acid. So people ask me, okay, patient comes with acute attack. He had 1 or 2 attacks. Why even bother of measuring uric acid? There's only one exception to that rule, which is evidence of hyperuricemia, very high hyperuricemia. And people debate about that level, but in my book, I will say anything above 800 or 900%, that's very high. And even if you don't have any of these indications, I will consider you to a candidate for hyperuricemic drug. So prophylactic treatment, this is the second most important. Initiation of acute acid-lowering drugs can provoke gouty attack. We've seen a lot of people who had their attacks, went home, they measured uric acid. By the time they come back to the polyclinic, their uric acid like 600. They put in allopurinol, after 6 weeks, boom, another attack of gout. Always overlap the drugs with one of our, with either NSAID, COX-2, or colchicine. Because theoretically what you're doing, you're lowering serum uric acid, and it can precipitate in the joint. So that's the importance of doing the overlap. I usually do the overlap for 2 weeks. It could be a colchicine, 1 pill a day, plus your allopurinol or the other drug, which is Uric, or it could be a non-steroidal like NSAID or naproxen. You can have your choice. Start with a low dose and stepwise increment together with prophylactic therapy. If you want to start allopurinol, you can start with 100 milligram. Always have an aim. You obviously want to prevent an attack, and you want to bring your serum uric acid less than 300. We've seen people being in allopurinol for 200 or even 300, but still their serum uric acid is like 500, and doctor is not helping me because we're not lower enough to prevent these further attacks. Do not start treatment during acute attack. This is by far the second common presentation we see in our clinic. People have their gouty attack. They did the uric acid level. In some part of the clinic, the report come back very quickly, and they started allopurinol on the same attack, and the attack actually got worse. They ended up showing up on an emergency. We have to start the oral steroids. Do not start a hyperuricemic drug during an acute attack. You have enough time. This is a long-term plan. Treat the attack for 10 days, then give them rest for at least a month, measure your serum uric acid, and then initiate your treatment if needed. There is no point of starting the hyperuricemic drug during the acute attack. If gout arthritis occurs in patients on drugs, do not stop them. This is for our people who are treating our patients inside the hospital, because we've seen people, they come for pneumonias or a mild elevation in their creatinine, acute renal failure, and then the immediate reaction of the trainees or the students who be taking care of this patient, they stop their hyperuricemic drug. Do not stop their hyperuricemic drugs. They've been on this drug for a long time, they tolerated this drugs, and if you stop it suddenly, you'll see a raise on their level, and actually can worsen their gouty attack. It also may take several months for drugs to work. So if you started your drug, whether it's allopurinol or Uric, give it some time, at least 3-4 months. There is no point of repeating your serum uric acid within a month and make the patient anxious about, okay, what's going to be, oh, it's only went down for 50 point or 10 point. No, give it some time, explain to them this is a long-term plan. You're going to be on this drug for a long time, and we're going to repeat your level in 4 months. So just quickly, last 2 slides talk about the drug. By far, allopurinol is the oldest drug and the most common drug used in Kuwait. It's a xanthine oxidase inhibitor. It started 100 milligram dose, and you can go up to 900. I've rarely seen people go beyond 300. Most of the time, we don't need to use more than 300, but there is a few exceptions. Those who've been on 300 for a long time, and their serum uric acid is still 450 or 500, we haven't reached the target of 300, and they still have recurrent attacks. And every time they have an attack, they're off for like 2 weeks. So that will be a candidate to increase their dose to up to 900. Reduce the dose of renal impairment. You know that allopurinol has a very narrow therapeutic index, and they can go in with the renal, especially with the renal failure patient. It's a very effective and well tolerated in the majority. In rare cases, can cause some GI upset and hypersensitivity. In 5% of the cases, we have seen a few cases of Steven Johnson or hemolytic anemias and the TN cases. But very importantly, remember that this drug interacts with the warfarin and Immuran. Immuran for our patients who are needed immunosuppression, like lupus patient or even some for other indication. Warfarin, because I told you, most of these people have other comorbidity, have reason to be in Coumadin. So if the patient is already on allopurinol and is starting warfarin, always be aware of the interaction. So this is the new drug that I told you about. It's actually been in Europe for the last 7 years, in North America around 6 years, and it's been in Kuwait around a year and a half, almost 2 years. The generic name for it is Fubicstat. The trade name for it is Uric. It is a selective xanthine oxidase inhibitor. It's appeared very safe in renal impairment, and even in the last 2 months there has publication about using it in the dialysis patient, and it seems to be safe. It is not recommended for patients with congestive heart failure, though. The doses in Kuwait, it comes in 80 milligram and 120 milligram. In in North America, it comes in the 40 milligram and 80. So I always tell people, if you think this is a patient, a candidate for hyperuricemia, and you don't like really allopurinol, or you have a contraindication of allopurinol, and you worry about the interaction with other medication, this will be a good choice. Renal failure patient, this will be a good choice. Because it comes in 80 milligram, always tell them take the tablet and make it in a half, so you actually give them a 40 milligram, and you go with your level. You repeat your uric acid within 4 months. If you reach your target less than 300, then 40 is more than enough. If you haven't reached your target, then you can actually increase it to a full tablet, which is 80 milligram. It rarely can cause nausea, diarrhea, and headache. So this was my presentation. I hope I went quickly over the triggering factor, what you're going to do when you face these patients, what are important diagnoses to exclude, what are your options of treatment, and how you're going to decide about whether you need to start hyperuricemic drug. Thank you very much.